Hello to everybody. It's my pleasure to moderate this interesting session at the TIF conference about accurate iron load measurement. In particular, the question will be how accuracy and reliability are ensured in iron load monitoring. I'm Alessia Pepe, professor at Institute of Radiology at the University of Padova, and it's a great pleasure to introduce Professor Malcolm Walker, University College Hospital, Clinical Director at Atter Cardiovascular Institute, London, UK. Professor Walker will talk about an overview of the best practices in clinical care today, the cardiologist's perspective. Please, Malcolm.
Hello, I'm Malcolm Walker. I'm a professor of cardiology at University College Hospital in London. As a consultant cardiologist, I've been involved in the care of thalassemia patients for many years, having set up a dedicated clinic for patients with hemoglobinopathies back in the 1990s. And in order to give a consensus or an overview what I think best practices in clinical care might be, I've subdivided into three broad, simplified areas to cover so that I could formalize thoughts. In terms of the tools that we require in cardiology, the MRI scan comes right at the very top for obvious reasons. It can actually measure, quantify the toxin that we're interested in that injures the heart and circulation. Echocardiography is central to cardiology. It's a way of looking at immediately in a very simplified bedside manner cardiac function, as does the ECG, which is somewhat neglected, but I'll briefly talk on that. And where ECGs are concerned, we need not only what the ECG is doing right now, but a capacity to monitor for longer periods of time. And then you've got some other issues like clinical databases and the ability to network between specialisms and hospitals. Where the MRI scan is concerned, I've learned from many years' experience, and particularly with experience in many different countries and systems, that fundamental to having reliable data is that the people undertaking the scans use sequences that are known to work in this circumstance. Secondly, in this group of patients, rather special and different to standard individuals going through scans, in that they are undergoing lifelong surveillance. And so scans can be focused and they can be optimized to answer specific questions in individuals. Having said that, in this group, as in any other, we need a minimum data set that we require in order to manage them. This includes, obviously, iron assessments in these groups, but quantification of chamber sizes, the anatomy, function, and nowadays, I think it can be said that we really are not using the vast amount of information that the MRI is giving us. We need to be more sophisticated in what we're looking at in terms of function, and that must now include parameters such as strain. And also it's really important that we look at the whole heart, look at what's happening in the both ventricles and actually also the atria. Interestingly, I think the experience in our group is that increased use of automated methodology to make some of these measurements improves the coefficient of variability. It's more accurate if you take humans out of the picture for some aspects of analysis. And when it comes to analyzing, particularly for iron, it's really important that validated methodology is used. Again, in my experiences in other countries, traveling widely, is that it's a bit of a mess. And you need to have had appropriately trained staff using software that is validated and does the job that we're looking for it. And then obviously it's a learning process, but it's very important to have these techniques properly done. The staff have to be trained, and again, with all our programs of work, doing fast MRI scans across the world. We've embedded within them training programs so local staff and can obtain the sufficient experience and ability to undertake this work. So appropriately trained staff is crucial. And getting patients through and the results out early is an important aspect of quality for managing patients. Having faster scans, and that's part of what we're talking about focusing, reduces burden of time for the individuals, particularly those undergoing regular surveillance. And it's also important economically for health systems in that it becomes more economic to do these scans. If you like, and I'll come to it later, but one of my views would be that the MRI scan should be, almost like a chest X-ray. You go in, you have it done, and you're out. In time, I suspect we'll get there, but not yet. Much the same can be said for echoes. The scans here in this group can be focused, pertinent to answer the questions you need. And again, they should use validated methodology. It's important that scanners do as they are taught to do and as is standardized in a lot of the international guidelines. So that's really important. Again, minimum data sets are really important to establish. And I think we have to get away from the old subjective visual, if you like, estimate of function, and we have to move to volumetric methodology where the coefficient of variation becomes much more practical and improved. So have to insist on volumetric ejection fractions. And you've got to include other parameters of function, such as tissue Doppler imaging, and more increasingly strain again. Less intuitive perhaps, but important, more sensitive, more specific in order to manage our patients. And of course, with the development of machinery, we should be prepared to at least adopt and look at newer parameters of function, for instance, looking more closely at atrial function. These tests, again, shouldn't be in an ivory tower, available only at certain times and after special pleading. They should be available at short notice. And as far as echo is concerned, this really should be something that is done in clinic as a one-stop process, so that the scan is done on the same day you see the patient, and that allows also to have a very rapid throughput for the individual. Where the ECG, this is a bit neglected, but again has to be standardized, and really a bugbear in my own institution, but it's available generally and widely. Archiving this data digitally has a huge advantage for the patient in terms of following up. And again with archiving, all the data is saved, so you can just go back and analyze it as you wish. For the long-term ECG recording, the modern methods with these wearable patches have a huge advantage, and should replace the older systems. And again, this kind of analysis should be rapidly available, and it should have access by non-specialists, is something I'll come back to. In order to understand our patients better and follow them at longer times, we do need databases of patient information, and the capacity to network more generally, because any one institution will have a relatively limited number of patients, and therefore networking allows bigger data to be analyzed and our understanding to improve. In terms of processes, integrating care with the hematologist at the center, integrating all the opinions of other specialists involved, and that might mean regular MDT meetings, combined consultations and the like. And it should be possible for clinicians to access data from all sources for individual patients. And access to appropriate testing by non-specialists with specialist oversight can improve patient care. Electronic patient records are very useful, and a centralized repository for certain data, anonymized, to allow research, benchmarking, and hypothesis testing or hypothesis generating is a really important quality metric. The system's got to communicate with each other, and we need resources to stop pinch points. The aims are fairly simply stated. We want our patients to do better, and streamlining the care to achieve that, I think, is an important aim, and that will also help avoid unnecessary duplication and repetition, which is difficult for patients and expensive for healthcare systems. And we need enough capacity to be able to respond rapidly when required to do so, and we should be flexible enough. We have enough data at hand to be able to innovate and evolve based on experience that is documented. And then part of the way of doing this is to ensure that all encounters with patients are an opportunity to learn and an opportunity for research. So with that, I'll stop and look forward to discussing my views with the group. Thank you very much for listening.
Thanks, Malcolm, for your presentation that, in my opinion, it has reflected your long experience on thalassemia. Now we are moving on an overview of the best practice in clinical care today, the pathologist perspective by Dr. Dimitris Kontouras, a pathologist at Mitera Hospital, Athens, Greece. Please.
Good morning to everyone. Mrs. President, first of all, I'd like to thank the organizing committee for this opportunity given to me to describe this very interesting topic. This is my disclosure. The relationship between iron and liver disease is getting more and more clear last years. And we know now that it is the time for hepatologists indeed, since liver disease is presenting very high incidence instead of the cardiological disease and death that is going down. It is important to stress that the main cause of liver disease is not liver failure, probably as expected, but mostly liver carcinoma. This is consistent with many different aspects of the same problem, and in the center of which there is the matter of iron overload, either too high or even in cohorts with an average or mildly elevated liver iron content. Despite that, hepatocellular carcinoma is rising fast as an incidence. And it is clear that in transfusion-dependent thalassemia patients, there is less progression to decompensated cirrhosis and end-stage liver disease than expected. And the increased liver disease in recent years is exclusively in the form of hepatocellular carcinoma. In the sickle cell syndromes, progression of fibrosis to cirrhosis and end-stage liver disease and liver failure represent the dominant pattern. It is important to point out that the model of hereditary hemochromatosis explains really well what happens and what is the real cause of hepatocellular carcinoma rising, because the strongest evidence of the carcinogenic effect of iron is hepatocellular carcinoma in the absence of cirrhosis in patients with hereditary hemochromatosis. And as we can see here in this picture, increased risk of complications can be seen in the area of hepatic iron, similar to heterozygous hemochromatosis. And we know that even optimal iron chelation level is within those ranges of hepatic iron load. The mechanisms are very well defined now. We know that in the end, we have DNA rearrangement and chromosomal instability And also, we know that iron overload and the high transfusion rate are the factors that immune cells and immunosurveillance for oncogenesis are suppressed. We also know that even when we do not achieve a response in LIC diminution, the patients have a much more favorable route in stabilizing liver fibrosis when we use drugs that are potent enough to keep the labile iron low, like deferasirox. And this is very well depicted here, seeing that we really can, with any of the treatment modalities that we have today for chelation, we can achieve that low levels of LPI, less than 0.4 micromoles. And it is clear that when circulating and liver non-transferring bound iron clearance capacities are exceeded, other cell types such as pancreatic beta cells or cardiomyocytes take up non-transferring bound iron with iron accumulation in their respective organs. Iron compartments that could be in interest for to follow up the iron accumulation could be the functional compartment, the erythroid precursors or other proliferating cell pools, the uptake compartment, the recycling compartment, storage compartment, hepatocytes and macrophages, and the circulating storage compartment that includes peripheral blood T lymphocytes. And of course, the fraction of iron that is not included in the storage compartment should be associated with proteins other than ferritin or enter the transit iron pool, also known as the labile iron pool. So iron overload pours out and in the plasma, in the cells, in the tissues, in the organs, and this excess is capable to cause reversible or permanent damage and death. Labile cell iron rises following prolonged exposure of cells to labile plasma iron or when faulty cell iron utilizing machineries lead to maldistribution of the metal. In terms of assessment of iron overload, the methods are very known and widely used, like ferritin, transferrin saturation, representing non-transferrin bound iron, the LPI, the MRI liver measurements for T2 star and the liver iron content, the squid method for LIC, and liver biopsy. Transferrin saturation should be preferred when we have to detect hereditary hemochromatosis, where it presents remarkable sensitivity, but it cannot be easily used or safely used for the general purposes of monitoring. All of the methods have advantages and disadvantages that are very well known, but we should take in mind that also availability and cost of each one are very important factors. The drugs we use present properties that are very interesting and give us the tools to get to individualized patient approaches for treatment, depending on the size of iron accumulation, such with iron depending on the rate of transfusions or properties of each chelation drug or the patient's tolerance to the drugs. Of course, the goal is the recommended values for iron, liver iron content is less than 7 milligrams of iron, but probably in the future, the target could be no better iron load than normal. So what could be a successful iron load monitoring in thalassemia and sickle cell disease? Probably suitability of the selected method according to level of iron overload, accuracy of the selected methods, precision in given personal tasks, availability of methods, applicability, safety, cost effectiveness, assuring compliance to treatments, appropriate chelation targeting, calculating chelation effectiveness, and calculating chelation iron removal rate. The hepatologist's perspective in all this is that given that hepatitis C in thalassemia is almost extinct, the remaining and principal hepatological perspective in hemoglobin disorder is treating iron overload by defining the optimal levels of LAC for a healthy liver, contributing to prevention of progression of fibrosis and liver failure through optimal chelation treatment and supportive liver care, close monitoring as an invaluable tool for chelation treatment precision, effectiveness, and safety for the liver, and also to select the most precise and accurate strategies in respect to availability and cost effectiveness every time of the alternative technical modalities. Above all, hepatological perspective means supervising a strict and effective surveillance for hepatocellular carcinoma in all cases in thalassemia and sickle cell disease as the major concern. The aim would be guidance and support for successful treatment of the liver iron overload, expressing the regulating storage of total body iron, and the consequent systemic complications of iron toxicity, aiming at adequate 24 control of the main cause and the final cause of the problems, that is LPI. So successful iron monitoring should include liver iron load and liver iron content monitoring reflected to total body iron load, and iron toxicity monitoring. In recommendations, initial determination of iron overload with measurement of LIC with MRI and ferritin, monitoring of iron toxicity in patients with high LIC by determination of LPI and liver function tests, and monitoring of iron toxicity in patients with normal LIC by determination of LPI, transferrin saturation, and the liver function tests. We can talk about long-term and real-time iron overload monitoring, and measurement of T2 star and LIC using MRI means long-term indicator with an initial indirect estimation of total body iron load together with ferritin levels as a surrogate or alternative indicator. And also measurement of non-transferrin bound iron and LPI as a real-time indicator of direct iron toxicity, and at the same time we can have measurement of transferrin saturation as a surrogate or alternative marker of adequate plasma iron buffering where this works. Because normal LPI reliably determines the effectiveness and safety of chelation treatment as a positively balanced outflow of iron, established as a series of events that are excretion from the tissue to the plasma, binding to the chelating agents, and finally being discharged. And as a general rule, we should monitor any indicator available and the cost-effective that reliably and real-time will measure both alternating risk factors for liver iron toxicity, NTBI and LPI, and transferrin saturation as direct toxicity fast indicators, LIC and ferritin, looking at total iron overload, and indirect toxicity as long-term indicators. High levels of iron overload present with more sustained saturation of the iron buffering system, so fast indicators are not reliable and useful, and low levels of iron overload and normal iron load are expected to interact with plasma and cellular buffering systems more satisfactorily, and therefore faster indicators should respond with the most reliable fluctuation. All these are expressed in the 2021 guidelines for the management of transfusion-dependent thalassemia by Thalassemia International Federation. And here we can read that magnetic resonance imaging using liver iron content is the method of choice for iron load monitoring thalassemia patients. Here, the LIC assessment should be performed in all patients in order to monitor chelation therapy effectiveness. Serum ferritin is the most widely used, of course, marker of total body iron load, but serum ferritin values higher than 2000 are associated with liver iron overload. However, Ferritin measurement has low specificity and should be interpreted with caution, since it can be elevated also in the case of concomitant inflammation, malignancy, or oxidative stress. Transient elastography will be useful in the future, and it has been used for the assessment of liver fibrosis in thalassaemic patients, and the values measured by transient elastography were found to be strongly correlated to MRI T2 star results. So LIC values, serum ferritin levels, and transient elastography stiffness measurements in patients with sickle cell anemia were also correlated and found to improve after successful chelation therapy, although this correlation was not confirmed by other studies, and further studies should be made in this direction. Thank you for your attention and patience.
Thanks to Dr. Contouras for his accurate overview on liver monitoring. Now we are moving to Dr. Evangelos Alexiou, consultant radiologist, General Hospital of Larissa, Greece. Dr. Alexiou will talk about an overview of the best practice in the clinical care to date, the MRI specialist perspective, please.
Good morning to everyone. It is a great honor for me to participate as a speaker in the 15th TIF International Conference, and I would like to thank the organizers for this kind invitation. In 2001, it was published a landmark paper by Anderson et al. With a new radio marker called T2 star. Over the years, it proved to have a great implication in the reduction in overall mortality and the cardiac complications in thalassemia, and the improvement in life expectancy as well. We would expect that today, accurate and widely available techniques for iron load measurement should be in our daily clinical practice, but is this the case? Which are the methods used for iron load measurement today? There are two main categories, the signal intensity ratio method and the relaxometry methods, which are further subdivided in the R2 relaxometry, the FerriScan, and the R2 star relaxometry. The signal intensity ratio method, although considered obsolete, has still its value due to the fact that it has a scaling sensitivity to iron overload. So it can be used as a complementary method to T2 star technique, maybe in selected patients with very high iron load, and that's because it's less sensitive to iron, and some of the T2 star pitfalls could be avoided, especially in patients with high iron load. This technique nowadays has been incorporated to a free online tool called MR TIF, developed by the University of Rennes. The R2 relaxometry has been tested in a variety of conditions, including thalassemia and primary hemochromatosis. And the R2 has been proved to have a significant correlation with the iron as assessed by liver biopsy. It seems to be unaffected from underlying conditions such as fibrosis and necroinflammation. Nowadays has approval from all major regulatory authorities and is the only valid method for clinical trials, and there is no need for training or post-processing, but it is a commercial product and has additional cost, and the method is only for the liver iron quantification. On the other hand, the T2 star or R2 star relaxometry as a method is a very fast technique. The mean acquisition time for each set of images is below 15 seconds on a single breath hold. It practically can be applied in every tissue, the heart, the liver, the pancreas, the spleen, the kidneys, or the bone marrow, or even the central nervous system. It is now incorporated in almost all major MRI scanners. This is a method of choice for the quantification of iron in the heart. And the myocardial R2 star has a strong and linear correlation with the biopsy iron. We know that the mid-ventricular septal is representative for the global iron in the heart. T2 star has also proved to have a good correlation with cardiac ejection fraction of the left ventricle. So with this knowledge, we were able to stratify the patients according to their T2 star value. And we now know that the patients we have are in high risk when the T2 star is below 10 milliseconds, are in a moderate risk when the T2 star is between 10 and 20 milliseconds, and they are in the green zone of low risk for systolic dysfunction when the T2 star is above 20 milliseconds. Furthermore, T2 star proved to be a powerful predictor for significant cardiac events in terms of heart failure and arrhythmias. So we know that at the level of 6 milliseconds, almost 50% of the patients are in risk of developing a significant cardiac event in the next 12 months. T2 star also has been proved to be accurate for liver iron load measurements, and this accuracy has been documented with many publications, and also has a good correlation with the ferry scan up to the level of 10 milligrams. Now, what are the issues with this otherwise very good technique? First of all, there is need for post-processing. And there are various ways that we can do this post-processing. We can do it with a simple Excel file as proposed by Professor Fernandez, but this is, of course, very time-consuming, as this has to be done by hand and image by image. There is another excellent online tool, which is free and has been developed by Professor Gandon from the University of Rennes, and it's called MR-TIF. Although it is a great research tool and had too many variables that someone can manipulate, unfortunately, it is not validated for routine clinical use. And of course, there are other sophisticated post-processing softwares, which are quite expensive, unless they are incorporated in the MRI vendors. Another issue is that there are some pitfalls for the calculation of the T2 star, especially in heavily overloaded patients. So not all the images contribute to the calculation of the T2 star, and especially in heavily overloaded images, patients, many of the images do not contribute and just represent the background noise. So someone has to be careful to select the actual images that can contribute to the information. And this is reflected by a specific index, which is the R-square, which has to be over 0.96, so as to be accurate calculation. Now, the T2 star is a value that is generated by the MRI scanner, but there was a need to translate this number to a liver iron concentration. So we tried to compare this, to translate this T2 star value to LIC, and this was done in comparison with liver biopsies. So there were many publications with these calibration curves, but unfortunately, there was not a very accurate agreement between these curves. So for example, if an MRI scanner generates a T2 star, which is 2.5 milliseconds, then depending on the calibration curve that we will decide to translate it to LIC, we will have a different result. Why did this happen? First of all, because the researcher used different acquisition parameters, which might have contributed to this variability. Furthermore, we know that the biopsy have many sampling errors, inter and intra-observer variability, and although is considered as a gold standard, there are issues with this technique. And last but not least, we know that the distribution in the liver is not homogeneous and there is heterogeneity So depending on the site that someone could sample with the biopsy needle, if this might have resulted in different results. So concluding, maybe it would be a good idea to try to validate the T2STAR technique with standardized acquisition parameters, possibly to develop a T2STAR calibration phantom instead of performing invasive liver biopsy calibration curves. And if this could be achieved, then it could serve as a reference for other parenchymal organs where the biopsy is not such an easy thing. Of course, the FAIR scan is always an option if cost is not the issue. In the recent years, there is great research regarding the role of T1 to detect the iron possibly better than the T2STAR. For the moment, the T1 and the T2STAR are considered as concordant in the established iron overload, but there is great evidence that the T1 might detect the missed iron in the normal T2STAR range between 20 and 30 milliseconds, and this possibly might affect 1 in 3 patients. Of course, the clinical significance of this low T1 in the normal T2STAR range needs further evaluation. Now, in the last slide, I would like to mention that beyond iron quantification, there is additional role of MRI in the clinical management of thalassemia with useful radiomarkers. For example, in the heart, there is a great role of the functional analysis, the myocardial strain, which possibly could early detect the subclinical cardiac dysfunction, the late gadolinium enhancement for potential presence of tissue scars, the extracellular volume. And we do not have to forget that because in the recent years, the hepatocellular carcinoma is continue increasing, there's a great role of MRI to early detect the hepatocellular carcinoma. And of course, this could be performed in the context of the annual MRI by adding dedicated images like diffusion weighted or contrast enhanced images. And with this, I would like to thank you for your time.
Thanks, Dr. Alexiou, for your presentation. Now it's my pleasure to introduce Dr. Andreula Eleutheriou, Executive Director for TIF, and Dr. Michael Agastaniotis, Medical Advisor for TIF. They don't need any presentation, but I need only to say thanks to them for your daily work on hemoglobinopathies. Dr. Agastinotios and Dr. Eleutheriou will discuss about why is this a concern for TIF. Please.
Well, thank you very much, Professor Pepe. First of all, it is our pleasure, and we express our gratefulness and appreciation for all of you for your contribution for the bettering of the health and quality of life of our patients across the world. Now, we have seen the very comprehensive presentations of why is accurate and specific, disease-specific iron load monitoring is required in our patient cohorts. And we are very well aware that iron load monitoring is a very important component of measuring and assessing the effectiveness of the chelation treatment we provide to patients. And chelation means better health, better quality of life, but also means costs to the governments or to the insurance or to the patients and families themselves who live in countries who are paying out of pocket for their healthcare services. Therefore, it is of great concern to ensure that these tools that you have very well expressed in your presentations, starting from Malcolm Walker to the hepatologist perspective, to Dr. Alexiou, who has added on to how MRI can additionally support the better assessment of various iron load related organs. Therefore, why is of concern? Because what you are expressing and what our guidelines are writing with regards to recommendations is not being practiced around the world. And the Global Review 2021, which I had a very long presentations and I asked to be erased because that would take valuable time from our discussion, which is much better to discuss and reach a consensus than actually document what I'm going to say now. Because what the results of the Global Review 2021 showed is that a very small percentage of our global population is actually receiving accurate iron load monitoring that receives quality validation, that it is assessed. Further to the fact that most of these services are not integrated into the financially supported services for the patients. In many countries, and I don't want to be so pessimistic to say in the majority of countries, the MRI and other iron load monitoring tools are actually towards an area of exploiting the patients and their families in systems where the patients and families pay out of pocket. But I need also to comment that even in Western countries, these are not in the context of reference centers and multidisciplinary care and receive attention in the context of assessment and quality standards and validation. Therefore, what we have shown in our report is that less than 10% of our population is actually receiving accurate and regular iron load monitoring as these are recommended in our guidelines, and less than 5% of those who receive actually are receiving in centers where there is a documented validation of the results. Therefore, although everybody or the majority of countries show that these tools are available, and indeed, if one has the time to go online to see our report, we have shown that availability of all these tools that you have extensively discussed may be present in the countries. What is not present is the validation, the standardization, and the effectiveness of this iron load monitoring. Therefore, we are here to reach a consensus for you to help us find solutions on how to expand this accuracy validation across the tools and across the countries, starting from very basic ferritin measurements, which are not also quality assured or validated in the lab. Basic tools, let alone MRI and other tools that you've been talking about. Therefore, we need an alliance, we need a way of putting forward a project that would integrate into these efforts the training of the MRI specialists, the training of the people who are actually using these tools, the networking with expert centers within the country or across countries within regions, so that there is a second opinion and a reassessment of the samples. We need to work with industry to see how we can expand the already validated testing that exists. But we need to find ways, because iron chelation is given without standardized, accurate iron load monitoring, in addition to the financial constraints that our patients are going through in receiving this service across the world. Michael?
Okay, thank you very much. Actually, Andrula has come straight to the point. And the point is that thank you to our speakers for presenting the state of art, if you like, what is really needed. However, we, from our point of view, want to know, what about those who cannot afford, those to whom it's not available? Let's take a clinic that looks after 1,000 thalassemia patients, which is very common in the Middle East and in Asia. And yet MRI is either not available or not affordable by the individual patient. So this is the puzzle. And one thing that I would like to hear a discussion on is, what can we do? What are the alternatives? What can we advise? For example, the heart. We hear from our colleagues in such countries that, oh yes, we're devising or following patients with other methods. For example, we do echocardiography and we look at serial ejection fraction measurements. But then again, echocardiography observer variation is even greater than MRI variation. So, Alessia, with your permission, can we ask the panel to discuss a little bit what else can we do for those who cannot afford, or to those which are not available?
Which is the greatest majority, because what you have been describing is confined to a few reference centers in a few Western countries, with very few exceptions outside the Western world, where more than 85% of our population lives. Thank you.
Thanks, Andreula. Thanks, Agustin, also for your words. In my opinion, TIF can have a bigger role in order to address this issue, because today we have the technique. Moreover, we are living a revolution, because I think in the next years we will pass from T2 star to T1 mapping, not only in the heart, but also in the liver. And anyway, we have the technique, we have the technique on top in a few centers, mainly in the West country, but we need to spread the methodology. And I think the first step could be an update of the consensus document about iron monitoring, because we are living a revolution, we have a new instrument, and then probably based on this consensus document, TIF could identify a commit in order to do an accreditation of the centers for iron monitoring. And if you do an accreditation as a TIF, you can do a guarantee for standardization, validation, training, quality control along the time, because this is another critical point in my experience. The problem it's not only to start with validated centers, but to control the quality a long time, because the physician can the scan can change, and so it's important. And if you build this network, it's also easy to do second opinion. And this is my idea, and I think TIF could have a big role.
How about, thank you so much. This really puts a lot of basis to our thoughts as well. How about Malcolm? Malcolm, you've started a very important project.
Indeed. I just, to highlight a couple of issues here. What I'm going to say is from a study that we completed in India, and has now just been accepted by one of the European heart journals, and you'll see this published in a moment. But this was a study in two centers in India, an urban center and a rural center, where we were able to do we can do 103 scans in 2 days by focusing and doing very rapid scans. Initially, we wanted to replicate T1 mapping as we had done in Thailand. However, the scanners were too old and unable to undertake. So we relied on T2 Star, but showed you could do it. And that meant the costs go, they're an order of magnitude less for the individuals. Just over 8 minutes was our average time for a complete scan. So, you know, you can do it. It takes some organization. However, what I would say from our experience, and this is in the publication, in the urban center, 80% of the patients had an T2 Star at some stage. Only 7% had any idea of what the results showed, which I think shows as a mismatch. You can do as many scans as you like, but if you don't link them to care, and I'm afraid that happens a lot, patients get the scan and it's not linked to treatment. In this study, we linked it to treatment, and over 12 months, we have shown a 23% reduction in cardiac iron. And we didn't do anything else other than give a recommendation, and there was a doubling in the uptake of more intensive chelation, essentially using both oral chelators combined, and that had an immediate effect. The other thing I would say, you absolutely need ownership of the local people. Unless you get that, it will not go any further. It'll happen when TIF or visiting groups like ourselves come. We attempted to set that up, and COVID got in the way. But with the major academic center in India, the AIMS Institute, the program was to roll out what we'd done in 2 centers to 7 centers that were then going to disseminate. And we had a whole cohort of AIMS cardiology and radiology doctors who have been with us, who are going to be the source of this rolling out. So ownership is required with an oversight from the center organizations such as TIF, coordinating with the local individuals. So our job, if you like, is to make the technology accurate and easier to adapt to local circumstances. But you have to have local buy-in, not only by the scanning, and there's a separation here in many countries between scanners and the people delivering care. You need to link those inextricably so that the information is used in a rational way. And I'm afraid that link doesn't exist in many places. I think as Professor Pepe, Alessia, you've already mentioned, much faster methodologies like T1 or even T2 Star mapping, we're finding very useful. It can be an instant screening tool. And we did that in Thailand, but that project was marred by the fact, really, we didn't get local buy-in from people who are delivering the care. The radiology and the MRI scanners did the work, but there was absolutely no buy-in from the people delivering care to patients, sadly. That's what I tried to do in India, which I think has been more successful. So I think the models are there. And, you know, I think, TIF, you've been incredibly successful at ensuring people have blood, that the blood is appropriately screened. You've have an amazing program that has ensured many people surviving today that didn't before. But now we need to move that one stage further forward. There is an alternative strategy, which is really quick and dirty, if I may say so. And that is everybody gets both oral chelators, no matter what, as a starting point. That's what we found is useful. And then if you could add on top justification by scanning, great. But start off by getting everybody on at least 2 chelators. You won't save everybody, but you'll help.
Aggressive chelation. Yeah. Thank
Sorry,
you.
that's it. I'll shut up now.
Okay.
Thank you, Mike. Thank you, Malcolm. Again, again, Professor Koundouras touched on the necessity to measure iron in the liver, and he made a very comprehensive analysis of why and where we stand. But again, these are data from reference centers, from centers that have this accurate monitoring. And thank God that we have these reference centers so that we can teach the world how important it is to control iron and improve survival, health, and quality care. Yes, Dimitri, do you also have any contribution?
Kalimera.
Kalimera.
Probably I might sound old-fashioned, but I believe that since we have lack of techniques or money, we should be reevaluating the classical monitoring parameters and be re-educated on them and try to find their correlation to the modern techniques. I think that having this discrimination to long-term and real-time or fast indicators is very, very helpful to design some studies for a future correlation with classical parameters to the MRI techniques, and try to find the secure ranges in which we can use the classical indices like transfer saturation and ferritin. First of all, we should start, when we do not have any other opportunity, we should start with a very, very well clinical evaluation for inflammation. We should not neglect the clinical approach from which we should start with. Inflammation is regulating the value of anything else that we are going to use to achieve iron monitoring. So trying to save MRIs, we can first, of course, start with very aggressive chelation, take the iron down very fast and within ranges that classical techniques, blood techniques, biochemical techniques can be effective. If we have LPIs, it's easier to have an LPI measurement than having an MRI. And repeatedly, and when we check repeatedly, we can find the curves that will be more secure and more easy to follow up larger numbers of patients. And from the hematological perspective, direct measuring of the real harm, that is free iron or even NTBI in the form of transfer saturation, could be excellent tools even for countries or for populations that do not have the way for more expensive modalities.
Shiro, this is
Question from the audience. The first one from Michael Abisad. Excellent consensus meeting. How important is to have strain function in echocardiography for thalassemia patients? If yes, it would be important to advocate for its importance. I don't know if Michael wants to do a comment about strain.
I think
Malcolm,
yeah.
Malcolm?
I think it's better than good old-fashioned ejection fraction. I think it changes earlier, but it's more technically advanced, and you need a machine that will give you. There is a problem with different platforms giving different absolute numbers, but I think that's less of a problem if you are looking longitudinally in individuals. So it is a marker. Sadly, I think all markers of function are rather late and give us information that tells us that our patient is already a long way down the road of having significant tissue iron loading. So yes, I think it's a great advance over, in this recent study in India, 103 people, everybody who came to us who'd had a previous echo, every single echo had an ejection fraction of 60%. And that's because no one's measuring it. They just look at it. Oh, it's okay, 60%. So there's a spurious accuracy when you quote a number. Beware. GLS may have some advantages, but it's really documentation and proper documentation is just as good.
I would like to add that also in MRI, probably we need to include the global longitudinal strain. There is, in order to detach a dysfunction early. Okay.
Indeed.
And I don't know if we have time. There are 10 o'clock. I ask to the organization if we have to move to the conclusion or we can continue.
Well, I think if there is any burning question or even Dr. Alexiou wishes to comment, but there is a question from Alessia,
Loris Brunetta.
from Loris Brunetta.
From Loris.
The main
Okay.
issue is
Okay, from Loris Brunetta, the main issue is the education of specialists. Technologies is there, guidelines are available. TIF did a lot since many years now, reaching the specialists to educate to educate them is still something needed. How to do that in countries where patients die at a very long age?
very young age.
Yeah, very young age.
Yeah. Yes, this is our problem, and this is the problem at TIF, that all our educational problems are around hematologists, pediatricians, and members of multidisciplinary group, including cardiologists, hepatologists. So these are specialties that are very close to better providing better quality. We are not reaching out, obviously, to educating MRI and radiologists. And that's one component that I agree with Loris, that the MRI specialists need to be part of this multidisciplinary care, because their assessment is affecting positively or negatively what the hematologists and the treating physicians are going to decide on. Therefore, it's part of the work that we need to put in our activities, and I agree, and Loris is aware of this.
However, Professor Alessia Pepe earlier on made a suggestion that TIF could have a team of experts to accredit centers and monitor their results, if you like. And
that's
now the question is, how practical is this? Does the panel have any suggestions as to how we go about it?
I think that an update, I agree with Loris, so we have guidelines, but I think we need an update because there are a lot of new data and the update of the guideline could be the occasion in order to create this panel for accreditation, because if TIF push for an update, TIF will indicate specialists based on their experience. The specialists will work together, and we will analyze the positive and negative aspect in this moment, 2021, and this panel could be the nucleus for the accreditation. In my experience, if you do accreditation, you rise the quality and you put together a clinician and expert of imaging, cardiologist.
So if you allow me, in conclusion, I think we will, based on what Professor Pepper said and the rest of you experts that I come to thank you once again. I think that there is a need first to update the consensus document on the tools and the availability and work together as a core group on how we would develop a training and educational program into which we can bring the MRI specialists and the kind of quality assessment, because as you know, accreditation is a difficult word to use, and there are accrediting sort of agencies that undertake to do this kind of work. But there is a way to get into these accrediting bodies and into these specialists. And I think that that's one of the things that we'll need to do at TIF, to update the consensus. First of all, form a core group, which I'm sure every one of you here will support us in this, and thank you very much in anticipation. So we can start by writing a basic paper to which we can circulate to all of you so that you can put your input into how we think we should move forward. And of course, we will need to review it through the board and our national groups, and because we need national support. Very important. You've said it all, and I think Malcolm focused on it. We need national support. Therefore, we need to put a document that will be attractive, that will be plausible and possible in the areas, that will address the different issues in countries and regions. So allow us as TIF to write the basic paper based on what has been said, distributed it to all, taking into account that each one of you will be part of this first initial core group. Michael, you agree?
No, I agree. Thank you.
And thank you again, the chairperson, for an excellent moderation and interaction.
Thanks to you.
Malcolm, Gundurasa, Alexiou, thank you so much. Thank you.
Thank you.
Thank you.